Hey guys, welcome back to St3 Hacks, and today's topic is going to continue on the pediatric theme, and we're going to talk about the limping child. Now, a limp in a child is not a diagnosis, it's a system. And let's first talk about what your framework of thinking needs to be around this. So if it's painless, I tend to think about DDH, developmental dysplasia of the hip. Think about leg length discrepancies and neuromuscular causes. If it's chronic pain, you want to think about Perthes disease, classically in the age group of 4 to 8-year-old. Slipped upper femoral epiphysis, a SUFI, typically in 10 to 15-year-olds. And then other things down your surgical sieve, such as juvenile idiopathic arthritis, tumors. And if there's acute pain, the 4 things I really want to rule out are firstly trauma, that includes NAI, septic arthritis, which is a surgical emergency, transient synovitis, which is joint inflammation following a coryzal symptom like a flu or a diarrhea, and then lastly, an indolent type infection of osteomyelitis. Another key concept that you need to understand about a referred pain to a joint is that of the Hilton's law. Hilton's law states that nerves supplying a joint also supply the muscles and skin over it. Hip pathology can present as knee pain, and the anterior branch of the obturator nerve contributes to this overlap in the hip and the knee. So in any child with knee pain, I must examine the hip. The second piece of knowledge that you really need to understand is the Kocher criteria that was identified in 1999. And the original Kocher criteria helps stratify the likelihood of septic arthritis by 4 parameters. And the acronym that I have is WIFE. W for white cells over 12, I for inability to weight bear, F for fever over 38.5 degrees, and ESR over 40. Later, this was modified into the modified Kocher's criteria in 2005, and they incorporated a CRP value of more than 20 milligrams per liter. This guides to a probability of septic arthritis and increases with each positive criterion. You should know how to remember the percentages. It's quite simple. So with 1 out of 4, it's 3%, 2 out of 4, 40%. At 3 out of 4, it jumps to 93%, and at 4 out of 4, there's a 99% probability that this will be a septic joint. Remember, it's not a diagnostic test, it's a probability tool. They guide suspicion, not decision-making in isolation. Now, why is septic arthritis a surgical emergency? There are 3 key reasons. Firstly is risk of systemic sepsis and septic shock to the child. Secondly, the pus that is released within a septic joint releases these proteolytic enzymes from the inflammatory cells, and this has a direct chondrolytic effect, which damages the cartilage, and this can begin within hours. And thirdly, rising intra-articular pressure can compromise the blood supply to these bones and risks avascular necrosis. Let's move on to talk about imaging. So you want to get an AP and lateral of the affected joint. In the hips, you can ask for a frog leg lateral and an ultrasound to assess for effusion. Now remember that the ultrasounds detect fluid but cannot distinguish between a septic arthritic joint and transient synovitis joint. And lastly, MRI is useful if the diagnosis is unclear or there is osteomyelitis that is being suspected. In that case, it's the gold standard. And in young children, this may require a GA, and it's pragmatic to coordinate imaging with a possible surgical washout under the same anesthetic if the suspicion is high. Dropping this in your answer can help you differentiate as a logistical, thoughtful surgical trainee and shows that you have real-life experience in managing these cases. Let's move on to our key concerns. So in a limping child with pyrexia, you should say that my priority is to exclude septic arthritis of the hip, but I must also consider things such as proximal femoral osteomyelitis, trauma including NAI, malignancy, transient synovitis, and age-specific conditions such as DDH under 5, Perthes between a 4 to 8-year-old, and a SUFI in adolescence. Systemic assessment is crucial. A limping child with night pain, pallor, bruising, or weight loss raises many red flags. Okay, so the guidelines that you need to know are management should align with the BOAST guidance on acute musculoskeletal infections in children, and the principle is largely urgent assessment and early senior involvement. In your triple assessment, you should ensure a thorough history, taking a Socrates pain history, coryzal history, pertinent pediatric past medical history, specifically of any metabolical, rheumatological, and immunocompromised conditions. In the examination, you should approach it in a look, feel, move manner, observe the patient to see if they can walk or weight bear, and say that I would examine the joint above and below. The joint above the hips would be that of the lumbosacral spine. You should then say that I would observe how the patient is holding their joint in position. A septic hip is often held in flexion, abduction, and external rotation, and this is a position of maximal capsular volume. In terms of your investigations, you want bedside observations to ensure that they're not septic. You want bloods including FBC, UNEs, LFTs, CRP, ESR, vitamin D profile, and blood cultures to complete your Kocher's criteria and get a holistic understanding of the patient. You want to get AP lateral and frog leg lateral x-rays, ultrasounds, and MRIs as we've discussed. In terms of your immediate management, you should consider giving them NSAIDs early when the referral comes, because often the anti-inflammatory nature of the medication helps improve their joint pain by the time you go see them. But your main priority is to rule out a septic joint. You should inform the consultant if you're suspicious of a septic joint and prepare the patient for theatre as indicated. Prep the patient by consenting and marking them with a consent form 2. Inform and liaise with the pediatric team for joint care admission on their ward, and speak to the anaesthetic team early to see if they're happy to do this case under their care, or consider a referral to a pediatric specialist hospital, which is often the case if the child is under 3 years old at District General. In terms of managing the patient surgically, they may push you to ask, how would you perform the washout? And the approach to the hip is the anterior approach. And we can talk about this in another episode where I go through the approaches you need to know in ST3. Now, to really stand out as a candidate, you want to close your management by talking about follow-up, which many people won't mention. So you want to say that you would discharge the patient only once they're apyrexial, the inflammatory markers have settled, and you have a confirmed antibiotic step-down plan with microbiology from the samples that you sent in theatre. You want to ensure close observation, and you want to review the patient in 1 week's time in your fracture clinic. And in the long term, you want to repeat radiographs in the 2 to 3 month period to exclude any signs of femoral head osteonecrosis or any signs of osteomyelitic changes. So that kind of covers your limping child, and I will do another episode talking about DDH, SUFIs, and PERTHs in more detail. So I'll catch you in the next one. Take care.